friends, I am Dr. Bharat Modi from Wellcare Hospital, Vadodara. I have spent what I would think is almost an entire lifetime working in the area of total knee arthroplasty and arthroplasty at large, but certainly much more focused on the total knee arthroplasty. And on request of my fellows and students, I have decided to come up with a series of lectures which will take you through what I would consider as a primer and as an overview of understanding the science and art of arthroplasty. Friends, if you have any inclination to go into further personalized discussions on this matter, you are most welcome to approach us at Wellcare Hospital. We will be exhibiting the contact information for that. And for any questions that you might have, it will be my pleasure to help you understand and navigate your pathway in this area of work.
So, good morning. Good morning. Today, what I propose we discuss is a relatively, it's not an obscure topic at all, but it is not part of the mainstream discussions either in large conferences or in any teaching programs as well. What typically happens is in the mainstream discussions, it's all about surgical approaches, the technique of handling various deformities, flexion deformities, viscous deformity, how to handle bone loss. These are mainstream discussion topics we come across again and again. And whilst the importance of patellofemoral joint kinematics in a knee replacement has of late become a very well recognized subject for discussion. It has always been well recognized since early days of total knee arthroplasty as a science and art. But as I say, it does not catch as much attention as it should, in my opinion, as part of the learning process in arthroplasty, science world. So what I propose to do is to do this lecture today and focus only on this aspect. Next. As we all know, TK is widely acknowledged to be one of the most successful procedures in orthopedic practice. Next. However, it has its own share of failures and reoperations. And surprising as it may sound, and that is why I feel that it is strange why it's only given one small 6 or 8 minute lecture and turbos, not even 6 minute lecture as a patellofemoral thing comes. Because more than 50% of reoperations, and this is well documented in literature again and again and again over the last 50 years, that more than 50% of reoperations after TK are related to the PF joint. You might think that the reason for, typically when you guys will talk about revision, you are talking about taking the entire implant system out and putting it again. And there it is usually due to either infection or aseptic loosening. But if you take reoperation as a definition, any cause reoperation as a definition of revising your primary surgical action, then 50%, in fact more than 50%, are related to the PF joint as a problem in total knee arthroplasty. And yet, the focus on the understanding of the patellofemoral joint kinematics is relatively speaking small compared to the other aspects of arthroplasty discussions. So whilst the largest femorotibial articulation usually takes the lion's share of attention, the PF joint is the one which ends up causing the most trouble. Next please. So, PF joint related problems. First and foremost, patellar instability and malleus. So, when you take a skyline view after your TK in your follow-up clinics, and if you see that the patella, instead of remaining well balanced within the trochlea, is pulled on one side, and that's called mal-tracking. And in the extreme case where it is actually so imbalanced that it can actually slip out of its position, then that's instability. Patella fracture. You asked me yesterday, I think, about rheumatoid arthritis. That is there a separate lecture for TKA in rheumatoid arthritis? Yes, actually, I was thinking about it later in the night. And I think, yes, there is enough material in terms of specific points that it can turn into a separate lecture on its own. because there are certain features of a well-established rheumatoid arthritis affected knee joint, demanding special attention to those issues, which in itself can be a small lecture. One of the issues would be that the bones are so osteoporotic that you would have finished everything well, and later, 3 months down the line, 6 months down the line, when you take a follow-up X-ray view, lateral view of that rheumatoid patient, and you will find that the patella has gone through a stress fracture. Why? Because, and you will see what I mean by it later in this lecture, that the pull of the extensor mechanism, especially if it is not well balanced, and if the knee joint does not have an easy range of flexion movement, and in the post-op phase, now the pain is gone for that patient. So the physiotherapy and the patient both are enthusiastically trying to get the flexion range of movement, and the osteoporotic patella starts giving way to a stress fracture. It is such a gradual process in those early 2-3 months that neither the physiotherapist nor the surgeon or the patient think of it as a separate pain, because it's part of the post-operative pain. It's only 3 months down the line if you take a routine view, and then you will say, oh, it has. The good news is that usually it is a slow process, and the extensor mechanism usually remains intact, so it's not like an acute fracture, and it usually does not require too much of a traumatic action such as.
So what is the relation between an unbalanced knee and a patella fracture in a rheumatoid arthritis case?
So the word balance, your thrust of your question is, what do I mean when I say the patellofemoral joint has to be well balanced? It's a good question, and you will find the answer to your question in the main part of my lecture. That is what the lecture is about. So good question, and let's hold on till then. So what are the issues related to the PF joint? One is the patella fracture, extensor mechanism disruption, avulsion. It's the same, it's different forms of presentation of the same issue. You can have a, if it's the lower pole of the patella which gets pulled off, then that's your patella, and that's much more dramatically devastating than this. Because here there will usually be some continuity of the retinaculum and everything, Or on the other end, the upper pole of the patella, if that, and that can be quite common. And the way to look at that would be if you see an extensor leg in either of these cases, but the quads pulling off is more common than the patellar tendon pulling off. But you will see a distinct dip here. So as and when you are looking at your post-operative patients in the outpatients, one of the things that you guys should do is to have a quick feel here, and there will be a distinct dip here with some amount of tenderness that the patient will exhibit here. And if it is large, then it would be worth opening it up and repairing it. And here, of course, the lower pole of the patella, you have no option. You have to go in and do a repair. And how to do a avulsed patellar tendon repair is a small topic in itself. We will not go there just now. Patellar component wear, loosening and breakage. Why this would be part of dysfunctional patellofemoral kinematics, you will see later in the lecture. Why this would occur. Patellar impingement syndromes. What do I mean by patellar impingement syndromes? The patella getting caught, and I think we did this discussion yesterday as part of that implant design discussions, that how, for example, a PFC sigma has a large box, and therefore during the excursion of patella, the patella can have impingement here, this side, so that, and residual anterior knee pain syndrome. Okay, so this is the group of problems and presentations that can happen. Next, please. This represents the most common reason for secondary surgery after total knee arthroplasty. The incidence of patellar maltracking ranging from subtle tilt subluxation to frank dislocation has been reported from anywhere as 0.5, which means almost none, to almost 30%. So look at the range. The reported results the reported incidence of a patellar maltracking instability type of a situation post arthroplasty in various articles have been reported with this range. So 30% means every third knee that was replaced had some sort of a patellar, and therefore no wonder that the reoperation rate goes above 50% when you take the total reoperation rate. Next please. So extensor mechanism imbalance, particularly tight lateral retinaculum. This is the most common issue. Why? Because it has to do with anatomy. You have your Q angle, and the native, a normal status of the anatomy has everything more or less aligned. You have your Q angle coming like this, and then the tibia goes straight, and your patella is sitting here. The trochlea of the femur is shaped to fit the patellar anatomy. The retinaculi are also supposed, in a normal situation, supposed to have developed in just the right manner so that they have just the right length and orientation of fibers. All this results in a pain-free normal patellofemoral joint function, which is what presumably all the knees in this room today have. The moment disease sets in, and here we are restricting the disease discussion only to arthritic knees. The moment disease sets in, this arrangement goes through a change. And the moment this arrangement goes through a change, there is reason for that knee to become symptomatic. And when you do a knee replacement, the aim is to correct the disease pathological state to a particular extent. But remember, no matter what we surgeons arrogate ourselves to, we can never become so smug with ourselves that we are actually creating that normal anatomy that nature has bestowed after about 1 million years of evolution. So it is stupid to think, no matter what alignment philosophy you approach or robotic platform you adopt, to think that you are actually recreating normal anatomy is childish at best, naive at its worst, if not foolish. So extensor mechanism imbalance, particularly tight lateral retinaculum, which is caused by disease pathology, patient morphology, and iatrogenic. What do I mean by iatrogenic? As part of your knee replacement, if you have done too much of anterior stuffing, either by oversizing the femoral component or choosing an implant design where it is this thick, So there are many different ways of how you can end up iatrogenically causing a patellofemoral dysfunction. By definition, you are changing the status. There is no doubt about that. So please distinguish between change of status that I alluded to in a moment back and causing dysfunction, which means pushing it to the point where it is now a problem. So next please. Causes. So what can be the cause of this iatrogenic? My focus is on that iatrogenic part here. So femoral or tibial component malrotation. Any of these mistakes can cause dysfunctional amount of pressure symptoms, and what is that pressure issue we will discuss in a moment, or tracking issue, which means instability, it all falling off altogether. It can either fall off from the trochlea or it can cause increased pressure as a result of this dysfunction. So what can cause this? Component malrotation or not proper positioning of your femoral or tibial component. Patellar button malposition, or the asymmetric resection is the same as malposition. So if you are a patellar surface replacer, which more than 50% of surgeons in the world are not, but if you choose to replace your patella as a part of your TK procedure, then a malpositioning of that button itself can be a problem in terms of the instability that it might result into. Prosthetic design of the femur end or patella. I told you that, let's say for example the PFC sigma has got a slightly thicker. So you have to be sensitive to that fact that the trochlea, and therefore more modern Attune, for example, or Persona, or all the modern designs, they dip the trochlea down into the femur. So this they dip it down by creating a small slot on the cut surface of the femur, so that this becomes low profile. Instead of it standing out like that, it dips down into, and therefore results into decreased pressure. And medial capsular dehiscence. Once in a while your suturing is not good. You have cut in the medial parapatellar approach, you have hardly left any tissue cuff on the patellar border, and now you have left it to the junior, and he does the best that he can, and the suture line is not at all good, and in the later post-operative phase it just sort of gives way, and that itself could be, you have done everything else good except that last suturing part, and it can lead into a patellofemoral issue. So very, very important. Not each and every one, but I have gone through 70% of these issues in my career pathway, 70%, including medial dehiscence. Doing it myself, and I have gone through that because I was in those days at your stage of my learning, and this is especially true for heavy-bodied patient. And when they go home and they sit on a low position like this, and just as they are lowering themselves, and at the last moment, it is too difficult for the quadriceps to do a graduated sitting, and they let go that last 3 inches, and that is enough of a jerk to separate that medial, and then rest is trouble.
So in terms of in terms of picking that up in the OPD, what are the things that we look out for? Do we look out for discharge? What is it like? How do you know that okay, it's time to open it up, go back in because we have no other option?
Very important point. So in the post-operative clinic, in the first couple of weeks itself, you will find that patient comes back with a suture line that is leaking out watery discharge, very thin watery discharge, because no suturing can be so strong that it can eventually prevent water from leaking out. If you have done it that tight, you are probably risking skin necrosis. So if there is a persistent watery discharge which is appeared suddenly, and then if you probe, and they might, many times the patient might say, and if it is persistent, if it is very little, you might want to hope that the opening is so small that fibrosis will take care of it as scar tissue forms. So you put the patient on a splint, stop all exercises 3, 4, 5 days. If it dries up, good. But if it persists and there is continuous, don't be afraid of telling the patient that this has happened. In the early part of your career, one of the most problematic part is that the young surgeon is always under pressure because of the sudden disappointment that they will see on the patient's face and family, and they are under pressure as if it is their fault that this has happened. Most times it might not be your fault actually, and even if it is your fault in the sense that that suture, 1 or 2 sutures that you took were not strong enough, that's part of this line of work. Face it, explain to the patient that this has happened, modulate your conversation appropriately so that they take it in the right spirit. Open it up. It's a very simple thing. Just open it up, take some secure sutures, and the results will be good. So femoral component malposition, internal rotation. As you can see here, what does it do? When you internally rotate a femur, so this is lateral, this is medial, or maybe the other way around. This is lateral, this is medial. And if you rotate the femur like this internally, then this edge will tent up. It will rise up, and that will tent up the lateral retinaculum, causing tightness. Excessive valgus. If you have done excessive valgus in your knee, see, most of your knees are in varus. And now again, this lecture was prepared at the time when Sam McDessie's CPAC classification had not yet given us a clarity of the various combinations that come along with the human knee, human lower limb arrangement. So if you are a mechanical aligner, and you are giving distal valgus cut, 5 degrees of distal femur cut at 5 degrees of valgus, right? What you are doing is, you are changing here and here. That's your Q angle. So you are changing the Q angle. And if you do too much of it, then that is the equivalent of widening the pelvis like this. आप समझ समझे? So if you increase your Q angle, the pull from the lateral side for a patella which is trying to stay in the middle in the trochlea is that much more. So there will be tightness here on the lateral retinaculum. So increasing the Q angle beyond a point also increases in the tightness of the lateral retinaculum. Femoral component rotation. Why is it listed in this slide? Because both of these are to do with the femoral component positioning as far as knee replacement is concerned. You know that Q angle or valgus is part of your distal femoral cut. That's why I have put it in this slide. Next please. Medialization, again continuing with the femoral component. If you medialize your placement like this here, or no, I have decided this is the medial side. So in that case here, so if I medialize it too much like this, then once again the femoral, the patella will be sliding here and there will be tightness in the lateral retinaculum. And lastly, overstuffing. I told you, if I keep on building up my anterior femur here, either because of thick component thickness or oversizing or anterior positioning of my, which is possible if you are doing a posterior referencing system. It is unlikely to happen in your anterior referencing methodology, which is what most people follow. But if you are doing your posterior referencing system, then yes, that is one of the problems of posterior referencing, that it can lead to overstuffing. Next please. Now we come to tibia. In the tibial component, in putting the tibial component in too much of internal rotation will cause the, once again the same thing. Either you increase the Q angle by increasing the valgus, or if you take the tibia in and then your Q angle increases, and that will increase your lateral vector. And medial placement of the tibial component is again the same as earlier we said. Next please. And patellar button malposition. So if you malposition the patellar button, again it creates an extra pull. Now this is surprising, this is counterintuitive. Think carefully, slow down your brain process and say, I am saying lateral placement of the patellar button underneath the patella will cause more tightness here. In the femur, actually this is an interesting phase of, at some point all of you must become familiar with putting a patellar button behind the patella. Here, the femoral component, if we put it laterally, we just mentioned that is the desirable thing to do. The femoral component. When you do that lateral, we just mentioned that that's the right thing to do, because if you put the femoral component too medially, it will cause extra tightness of the lateral retinaculum. Why? Because along, and now I am also answering the question I have posed for you. Think of this as a capture mechanism. The more...
What is the question that you posed? I think I missed it. What is the question that you posed?
The question that I posed for the audience was that this patellar button malposition, in that sense, when I am saying the lateral placement of the patellar button will cause an extra pull on the lateral retinaculum. Have you been able to understand it in your mind's eye, why a lateral positioning of the patellar button will cause an extra pull? And that I am trying to delineate for you.
Because even though the button is placed laterally, eventually now it is the components that have to position themselves according to the anatomy of the component. So the trochlear groove is medially, but the button is placed laterally. So automatically the button tries and sits into the groove, which creates that lateral pull on the.
Exactly. So think of the trochlea and the button as a capture mechanism for each other, or this is a capture for that button. So if you put the button laterally, it will have to slide in here towards this direction, and that way it will cause stretch on the lateral retinaculum. So this is an important part of patellar button replacement, which we will demonstrate in the theatre one of these days. Next, please. So now the common theme. The PF joint kinematics in total knee arthroplasty surgery has a propensity for the following. Propensity: extensor mechanism tightness, or in other words tension within this envelope, extensor mechanism. Lateral retinaculum stretch here. This overall, another is from here, and increase in the lateral vector, which is actually a result of this. Lateral vector means the patella going out laterally. Next, please. And what are the impact of all this? Crepitus. You will find anterior crepitus. Patellar stress fracture. I just spoke about it earlier. Anterior knee pain because of the stretch of these tissues, etc., or pressure on the patellar surface. Anterior knee pain. Patellar impingement and clunk. This is also got to do with the design of your femoral component, but given the fact that you have that design, any excessive tightness will then press the patella against that box here and cause that extra issue of clunk. Clunk is when there is a hypertrophic scar tissue on the superior pole of the patella, and therefore in a replaced knee, when the patient goes into 90 degrees flexion, that nodule like structure, it sits here in that box here, and then when they try to extend, it grates and track. So that's almost like a trigger, and you will inevitably come across this in your career. And it is important to understand this because you can easily correct this with an arthroscopy procedure. So, and the results are so satisfying and dramatic for the patient. So recognize a patellar clunk as and when it presents itself, or even a patellar crepitus if it is not an out and out thing. And the way to recognize it, that the patient will say, okay, they get this trouble only on two actions. One is when getting off chairs or low sitting positions, or while climbing stairs. And they will themselves, if you ask a proactive, what happens during walking? Sir, walking, no problem. While walking, I have no problems because the knee doesn't flex to the point where that nodule engages with that box. So you have patellar impingement or a patellar clunk syndrome. The crepitus is part of that, but this is when this gets amplified. Patellar component loosening, wear and breakage. If all this is part of your patellar button replacement procedure, then later on all this extra pressure and force, etc., can result into any of these things as far as that button is concerned. And lastly, extensor mechanism disruption. We already talked about quads or the patellar tendon disruptions. We talked about it a few minutes back. Next, please. Whilst these negative functional outcomes have been well understood and established, the role of PF joint and the extensor mechanism has not been recognized as contributing to. All this is already, this is where my original contribution started in those days. My main regret in life as far as my professional career is concerned is that while I have grasped and am capable of elucidating the finest of nuances of the science and art of arthroplasty, I have not been able to allocate enough time to turn all those things into publishable material of scientific level. I didn't have the time. I wore too many hats in my life, and otherwise this is, I think at this age and point in my career, I can legitimately claim that this is my original idea and understanding that the ability to achieve high flexion post-operatively directly as a result of the PF joint mechanics. This is my original contribution to this, which I have conveyed in multiple times in loud and clear terms, and other bright brains have picked it up and then turned it into publishable material and incorporated it into implant designs across the world. And I am happy for it. To protect the other thing, to protect the posterior one-third of the tibial plastic from increased pressure during high flexion position. And you will see what I mean by this. Here, the posterior one-third in the lateral side view, this posterior one-third of the plastic. Here, the pressure on this plastic, when the knee goes, when a knee replaced knee goes into deep flexion like this, the pressure generated here is directly proportional to the tension in the extensor mechanism, and I'll demonstrate all this later. Next, please. So, we conducted 2 studies. Next, to determine whether achieving high flexion was possible if certain surgical steps related to the PF joint were routinely incorporated in the operative procedure whilst using a standard implant, not specifically designed for high flexion. A wave had come because when Asia as a market became significant, the Western device manufacturing companies, which were the main proponents of this industry, they saw the market and they also recognized that the Asian population, for them, a good result is only when they can achieve high flexion, because most Asian populations have ground culture habits. And they put forth implants on the market which were labeled as high flexion designs. Although, and that's a topic for another lecture, and which I have debated against the greatest of legendary names in our area of work of arthroplasty, and won. And those are fun lectures, and I'll take it next time. So, while using a standard implant, not specifically designed for high flexion. Next, please. So, implant used. It is a standard implant. PFC Sigma fixed bearing. As you can see, it's got a very wide box. Though the first generation or the previous generation of PFC Sigma had a very sharp edge here. Next, please. Exclusion criteria of this study was any history of previous trauma or surgery on the knee or limb which would prejudice post-TKF flexion. Remember, my aim was to show that if I incorporated one particular surgical step related to the PF joint in my overall repertoire of surgical action of knee replacement, and whether that group of patients ended up getting a higher range of flexion post-operatively. Next, please. So, inclusion criteria, knees degenerative changes either from OA or RA with symptoms severe enough for the patient to undergo TK. In other words, a standard, box standard OPD that I would have had in the Indian context. Next, please. This is the patient data, number of knees where this disease, this, etc. Next, please. The BMI, the mean was 26. So, it was not as if I had a very heavy population, but at the same time, it was not as if I didn't have some who were also heavy. The pre-op range of movement average was 115 degrees. Pre-op. The valgus deformities, they were not severely deformed knees, because I didn't want to prejudice it by going into very severe. But 18 degrees is a reasonably good. It would represent, off the top of my head, I would say 85% of the population which will end up on the table for a knee replacement surgery. 18 degrees of varus or valgus. And similarly, flexion deformity up to 14 was what was present in my population, because there was no point my trying to put in 90-degree flexion deformities. They are too extreme, So, next, please. So, this is what the typical OPD range was in those days, and still is actually, except that you will now find increasingly less number of these very, very severe cases even in the Indian context. Next, please. So, average follow-up was 12 months, and this is considered adequate for this type of study. That at 12 months what you get, if you have documented, then you are okay. Next, please. Definition of target patient's ability to achieve flexion of at least 135 degrees in the operated knee, and this is required for ADL activities of daily living such as cross-leg sitting. And this I had published earlier because nobody, when I came back home and started focusing on this high flexion thing, and I realized that we keep on talking about cross-leg sitting, but nobody has defined in the literature what is cross-leg sitting in actual medical terms, Next please. So you can go to the Journal of Arthroplasty of 2008, this volume, and you will find range of movement of lower limb joints in cross-leg sitting posture. These guys, Amit Kapoor, etc., these were my fellows. But in those days, I had fellows who were ready to put in the work required to write up what I was doing, So, just an inspiration, I hope, for the present generation. So, the only other guy who had written something on these lines was this Tarabichi. He used to work in the Middle East, and he had written something for kneeling, not for cross-leg sitting, but the Muslim population in the Middle East would have the kneeling position as part of namaz. So he had written something on that. Next please. Factors known to be, so again, what are the factors which are already known to be instrumental in impacting the post-operative flexion after knee replacement? So there are patient-related factors such as the pre-operative range of movement, or the body mass, or the motivation level. For example, a vast majority of Caucasian population, they don't need that level of flexion, so they don't work towards it. And of course, the diagnosis. For example, if you had some strange diagnosis like systemic lupus erythematosus, etc., And what are the surgical technique related factors? The posterior femoral offset and femoral rollback. We discussed this yesterday, that the implant design, the way in which a knee goes into deep flexion is by doing a roll. And why is it called a roll back? It's also a roll, it rolls back. So it is not like, see here, if I just do this, the posterior cortex is hit by the posterior tibial lip. Do you see that? And that's the end of the range of movement. Again, if I don't roll the femur back, just sort of make it go into flexion, but staying in the same position on the tibial plateau as it is, and here it has now hit the posterior cortex. And now see what happens when the knee goes into flexion, but the way in which the human anatomical knee goes, as very well documented by Michael Freeman. We talked about Michael Freeman the other day. And Pinskarova, a Hungarian lady surgeon. They did some phenomenal MRI studies of the knee going into deep flexion, and they realized that the knee goes into deep flexion by medial pivoting. So it goes like this. It's not a pure movement like this, nor is it also the rollback that the world had thought like this, with both the condyles rolling back like that. And see, when you do that, I can go into this much of flexion. Without rollback, this. With rollback, this. Are you able to appreciate this? Every one of you. Ashay? Is it clear? So the rollback is an extremely important part of achieving higher flexion.
What about the medial pivoting?
So now I am coming to that.
What about the medial pivoting?
Very good. So, the previous to the medial pivot concept, the appreciation of the scientific or surgical fraternity was that there is a femoral rollback, but it is the same on medial and lateral side, both same, like this. It was only after Freeman's paper, Pinskarova's paper, that it was realized that actually the knee goes, if this is the lateral, although I am making the mistake. So the medial pivot, I should have done it there. But anyway, for the moment now presume that is your lateral, my side is the medial. Although it's the other way around as far as this anatomy is concerned, it's okay. For the purpose of this demonstration, I can show you. As I am going into flexion here, the medial side remains where it is. It doesn't go into a rollback. It just pivots on the long axis like this, and it's the lateral condyle which goes like this of the, so the lateral condyle almost subluxates like this. I am exaggerating to make my point, like this. So the femoral rollback is not like that in the human knee. The femoral rollback is like this. And now, and there are beautiful studies with dynamic MRI and also MRI, static MRI images. And that is why the arthroscopic surgeons amongst you would have observed that the lateral meniscus is so much mobile in its posterior 1/3. The lateral meniscus actually is capable of subluxating off the tibial lip along with the femoral condyle. And in those populations who go into deep flexion like we Indians do during squats, what is actually happening is the lateral femoral articulation, lateral tibiofemoral articulation is almost subluxated off like this, like this. So it is not a pure rollback of the entire femur. It is a medial pivot and a rollback of the lateral femur. So that aspect.
So, sir, there is some component of external rotation as well.
Of course, by definition. That is what the entire the pivoting is. What is the pivot? The pivot is that the medial is a ball and socket thing, medial articulation, like this, whereas the lateral is actually a roller movement, like this, instead of like that.
Next, please. So it's wrong. I think I will correct it. You were very obvious. You already gone past. So I thought it would be a quick lecture, but actually it is a two-part lecture. Now I can see that. So remember up to this point, and we'll take it up planning day after tomorrow if we get a chance. Or the next time we sit down, we'll do the second half. But it is a very important and detailed understanding of the PF10 dynamics will raise your knowledge level as compared to your peers by a full army. I can assure you that. Very good. Thank you.